Hi, this is Amber Knowlton. This is Nursing 2212, Unit 3, Coronary Artery Disease in your Lewis text, Chapter 34, pages 730 through 740. Coronary artery disease is the most common type of cardiovascular disease, and it accounts for the majority of these deaths. Patients with coronary artery disease can be asymptomatic or may develop chronic stable angina or chest pain. Unstable angina and myocardial infarction are more serious manifestations of CAD and are termed acute coronary syndrome. The American Heart Association estimates that 1.1 million Americans will have an MI each year, and about 1/4 of these will die in an emergency department or before reaching a hospital. Although the mortality rate from MI has decreased due to advances in treatment, it remains the leading cause of death from all cardiovascular diseases and death in general. Atherosclerosis, coronary artery disease, is a type of blood vessel disorder that is included in the general category of atherosclerosis. The term atherosclerosis comes from two Greek words, athery meaning fatty mush and scleros meaning hard. This combination indicates that atherosclerosis begins as soft deposits of fat that harden with age. Consequently, it is common to refer to atherosclerosis as hardening of the arteries. Although this condition can occur in any artery in the body, fatty deposits prefer the coronary arteries. The term atherosclerotic heart disease, cardiovascular heart disease, ischemic heart disease, coronary heart disease, and CAD all describe this disease process. Atherosclerosis is the major cause of coronary artery disease. It is characterized by deposits of lipids within the intima of the artery. Endothelial injury and inflammation play a central role in the development of atherosclerosis. The stages of atherosclerosis in this picture, A, the endothelium, the inner lining of the vessel wall, is normally non-reactive to platelets and leukocytes, as well as coagulation, fibrinolytic, and complement factors. However, the endothelial lining can be injured as a result of tobacco use, hyperlipidemia, hypertension, toxins, diabetes, and infection causing a local inflammatory response. Coronary artery disease is a progressive disease that develops over many years. When it becomes symptomatic, the disease process is usually well advanced. The stages of development in atherosclerosis are a fatty streak, a fibrous plaque, and a complicated lesion. So in picture B here, you see the fatty streaks. The earliest lesions of atherosclerosis are characterized by lipid-filled smooth muscle cells. As streaks of fat develop within the smooth muscle cells, a yellow tinge appears. Fatty streaks can be seen in the coronary arteries by age 15 and involve an increasing amount of surface as one ages. In picture C, here on your screen, the fibrous plaque stage is the beginning of progressive changes in the endothelium of the arterial wall. These changes can appear in the coronary arteries by age 30 and increase with age. Once endothelial injury has taken place, lipoproteins transport cholesterol and other lipids to the arterial intima. Collagen covers the fatty streak and forms a fibrous plaque with a grayish or whitish appearance. These plaques can form on one portion of the artery or in a circular fashion involving the entire lumen. The result is a narrowing of the vessel lumen and a reduction in blood flow to the distal tissues. Picture D on the screen. The complicated lesion, the final stage in the development of atherosclerotic lesion, is the most dangerous. As the fibrous plaque grows, continued inflammation can result in plaque instability, ulceration, and rupture. Once the integrity of the artery's inner wall is compromised, platelets accumulate in large numbers, leading to a thrombus. The thrombus may adhere to the wall of the artery, leading to further narrowing or total occlusion of the artery. At this stage, the plaque is referred to as a complicated lesion. C-reactive protein, or CRP, is a protein produced by the liver. It's a nonspecific marker of inflammation. It is increased in many patients with CAD. The level of CRP rises when there is systemic inflammation. Chronic elevations of CRP are associated with unstable plaques and the oxidation of LDL, low-density lipoprotein cholesterol, further contributing to atherosclerosis. Normally, some arterial anastomosis or connections termed collateral circulation exist within the coronary circulation. Two factors contribute to the growth and extent of collateral circulation: the inherited predisposition to develop new blood vessels, angiogenesis, and the presence of chronic ischemia. When a plaque occludes the normal flow of blood through a coronary artery and the resulting ischemia is chronic, increased collateral circulation develops. When occlusion of the coronary arteries occurs slowly over a long period, there is a greater chance of adequate collateral circulation developing, and the myocardium may still receive an adequate amount of blood and oxygen. However, with rapid onset coronary artery disease, such as familial hypercholesteremia or a coronary spasm, time is inadequate for collateral development. So consequently, the patient has a diminished blood flow, and it results in a more severe ischemia or infarction. In the picture here of vessel occlusion with collateral circulation, picture A shows a nice open functioning coronary artery. Picture B shows a partial coronary artery closure with collateral circulation starting to be established. In picture C, total coronary artery occlusion has occurred with collateral circulation bypassing the occlusion to supply blood to the myocardium. Risk factors for coronary artery disease. Modifiable risk factors include elevated serum lipids, elevated blood pressure, tobacco use, physical inactivity, obesity, diabetes, metabolic syndrome, psychologic states, and elevated homeocysteine levels. Elevated serum lipids. An elevated serum lipid level is one of the 4 most firmly established risk factors for coronary disease, and this can all be changed with diet changes. The risk of coronary artery disease is associated with a serum cholesterol level of more than 200 or a fasting triglyceride more than 150. For lipids to be used and transported by the body, they must become soluble in blood by combining with proteins. Lipids combine with proteins to form lipoproteins. Lipoproteins are vehicles for fat mobilization and transport and vary. They are classified as HDLs, LDLs, or VLDLs, the very low density. HDLs carry lipids away from arteries and to the liver for metabolism. This is why we want to have high serum HDL levels. They're desirable and they lower our risk for coronary artery disease. In general, HDL levels are higher in women, they decrease with age, and are low in people with coronary artery disease. Physical activity, moderate alcohol consumption, and estrogen administration increase HDL levels. LDLs contain more cholesterol than any of the lipoproteins and have an attraction for arterial walls. Elevated LDL levels correlate most closely with an increased incidence of atherosclerosis and coronary artery disease. Therefore, low serum LDL levels are desirable. So we want high HDLs because they take cholesterol to our liver to be metabolized, and we want low LDLs because LDLs like to go to those arterial walls and cause an occlusion. Guidelines for treating elevated LDL cholesterol are based on a person's 10-year risk for having a non-fatal MI or dying from a coronary event and his or her LDL levels. So they make the risk based off the patient's age, gender, use of tobacco, systolic blood pressure, use of blood pressure meds, total cholesterol, and HDL cholesterol. Hypertension, the second major risk factor in coronary artery disease, is hypertension, which is defined as a blood pressure of greater than 140/90 or 130/80 if the patient has diabetes or kidney disease. Hypertension increases the risk of death from coronary artery disease tenfold in all persons. The stress of an elevated blood pressure increases the rate of atherosclerotic development. This relates to the shearing stress that causes endothelial injury. Therapeutic lifestyle changes should begin in people with pre-hypertension. Those with stage 1 or 2 hypertension often require more than one drug to reach therapeutic goal. A third major risk factor in coronary artery disease is tobacco use. The risk of developing coronary artery disease is 2 to 6 times higher in those who smoke tobacco or use smokeless tobacco than in those who do not. Tobacco smoking decreases estrogen levels, placing premenopausal women at greater risk of CAD. Risk is proportional to the number of cigarettes smoked. Changing to lower nicotine or filtered cigarettes does not affect the risk. Nicotine in tobacco smoke causes catecholamine, which is epi and norepi release. These neurohormones cause an increase in heart rate, peripheral vasoconstriction, and an increase in blood pressure. These changes also increase the cardiac workload. Tobacco smoke is related to an increase in LDL, which is the bad cholesterol, and a decrease in HDL, which is good cholesterol, and release of toxic oxygen radicals. All of these add to vessel inflammation and thrombosis. Carbon monoxide, a byproduct of combustion found in tobacco smoke, affects the oxygen carrying capacity of hemoglobin by reducing the sites available for oxygen transport. Thus, the effects of an increased cardiac workload, combined with the oxygen depleting effect of carbon monoxide, significantly decrease the oxygen available to the myocardium. There is also some indication that carbon monoxide is a chemical irritant and causes injury to endothelium. The benefits of smoking cessation are dramatic and almost immediate. CAD mortality rates drop to those of non-smokers within 12 months. However, nicotine is highly addictive and often calls for intensive intervention to help people quit. Chronic exposure to environmental tobacco, secondhand smoke also increases the risk of CAD. People who live in the same household as the patient should be encouraged to stop smoking. This reinforces the individual's effort and decreases the risk of ongoing exposure to environmental smoke. Pipe and cigar smokers who often do not inhale have an increased risk of CAD, similar to those exposed to environmental tobacco smoke. Physical inactivity is the fourth major modifiable risk factor. Physical inactivity implies a lack of adequate physical exercise on a regular basis. An example of health-promoting regular physical activity is brisk walking 3 to 4 miles per hour for at least 30 minutes, 5 or more times a week. Physically active people who have increased HDL levels. Exercise improves thrombolytic activity, reduces the risk of clot formation. Exercise also encourages the development of collateral circulation in the heart. Obesity, the mortality rate from CAD is statistically higher in obese persons. Obesity is defined as a BMI of greater than 30 kilograms and a waist circumference. Let me back up. Sorry. Obesity is defined as a body mass greater than 30 and a waist circumference greater than 40 inches for men and 35 inches for women. The increased risk for CAD is proportional to the degree of obesity. There is also evidence that people who tend to store fat in the abdomen, rather than in the hips and buttocks, have a higher incidence of CAD. As obesity increases, the heart grows and uses more oxygen. In addition, there is an increase in insulin resistance in obese individuals. The incidence of coronary artery disease is 2 to 4 times greater among persons who have diabetes, even those with well-controlled blood glucose levels, than the general population. The patient with diabetes manifests CAD not only more frequently, but also at an earlier age. The person with diabetes has an increased tendency toward endothelial dysfunction. This may account for the development of fatty streaks seen in these patients. Diabetic patients also have alterations in lipid metabolism and tend to have high cholesterol and triglyceride levels. Management of diabetes should include lifestyle changes and drug therapy to achieve a hemoglobin A1C level less than 7. Metabolic syndrome refers to a cluster of risk factors for CAD, whose underlying pathophysiology may be related to insulin resistance. These risk factors include obesity, as defined by increased waist circumference, hypertension, abnormal serum lipids, and an elevated fasting blood glucose. Question: 2 risk factors for coronary artery disease that increase the workload of the heart and increase myocardial oxygen demand are B, an elevated blood pressure and cigarette smoking cause vasoconstriction. They increase the rate of atherosclerosis. Atherosclerosis increases the workload of the heart and increases myocardial oxygen demand. Next question. Which patient is most at risk for developing coronary artery disease? A, the 4 major modifiable risk factors for coronary artery disease are elevated serum lipids, which we change with diet, hypertension, tobacco use, and physical inactivity. Other risk factors include diabetes, metabolic syndrome, psychologic states, high levels of homocysteine, and substance abuse. The appropriate management of risk factors in coronary artery disease may prevent or modify or slow the progression of the disease. In the U.S., during the past 26 years, there has been a gradual and persistent decline in cardiovascular-related deaths. The decline relates to the efforts of people to become generally healthier, as well as advances in pharmacology and technology to treat CAD. Prevention and early treatment of heart disease must involve a multifaceted approach and needs to be ongoing throughout the lifespan. We want to identify those high-risk persons. Clinical manifestations of CAD will not be apparent in the early stages of the disease. It's extremely important to identify people at risk for CAD. Risk screening involves obtaining a thorough health history, questioning the patient about a family history of heart disease and their parents and siblings. We want to make note of any cardiovascular symptoms, assess their environmental factors, eating habits, their type of diet, their level of exercise to elicit lifestyle patterns. Include a psychosocial history to determine tobacco use, alcohol ingestion, recent stressful events, and the presence of any negative psychological states such as anxiety, depression, anger. The place of work and the type of work provides important information on the kind of activity performed, exposure to pollutants or noxious chemicals, and the degree of stress associated with work. Identify the patient's attitudes and beliefs about health and illness. This information can give some indication of how disease and lifestyle changes may affect the patient and can reveal possible misconceptions about heart disease. Managing high-risk people. We want to recommend preventative measures for all persons at risk for CAD. Risk factors such as age, gender, ethnicity, genetic inheritance, these cannot be modified. However, the person with any of these risk factors can still reduce the risk of CAD by controlling the additive effects of modifiable risk factors. For example, a young man with a family history of heart disease can decrease the risk of CAD by maintaining an ideal body weight, getting adequate physical exercise, reducing the intake of saturated fats, and avoiding tobacco. People who have modifiable risk factors should be encouraged to make lifestyle changes to reduce their risk of CAD. As a nurse, we play a major role in teaching health-promoting behaviors. We want to teach patients to know how to reduce their risk. This may be the information that they need to get started. For persons who are less motivated to take charge of their health, the idea of reducing risk factors may be so remote that they are unable to perceive a threat of CAD. Few people desire to make lifestyle changes, especially in the absence of CAD and symptoms. You should first assist these patients in clarifying personal values, explain the risk factors, and have them identify vulnerability to various risks. You may help them recognize their susceptibility to CAD. This may help patients set realistic goals and allow them to choose which risk factors to change first. Some persons are reluctant to change until they begin to manifest overt symptoms or actually suffer an MI. Others, having suffered an MI, may find the idea of changing lifelong habits still unacceptable. You must be able to identify such choices and respect them. Physical activity. A physical activity program should be designed to improve physical fitness by following the FIT formula. FIT meaning frequency, how often, intensity, how hard, type, isotonic, time, how long. Everyone should aim for at least 30 minutes of moderate physical activity on most days of the week. In addition, adding weight training to an exercise program 2 days a week can help treat metabolic syndrome and improve muscle strength. Examples of moderate physical activity include brisk walking, hiking, biking, and swimming. Regular physical activity contributes to weight reduction, reduction in systolic blood pressure, and in some men, more than women, an increase in HDL, cholesterol. Nutritional therapy. The National Heart, Lung, and Blood Institute recommends therapeutic lifestyle changes for all people to reduce the risk of CAD by lowering their LDL cholesterol. These recommendations emphasize a decrease in saturated fat and cholesterol and an increase in complex carbs, whole grains, fruits, vegetables, and fiber. Red meat, egg yolks, whole milk products are major sources of saturated fat and cholesterol and should be reduced or eliminated from diets. If the serum triglyceride level is elevated, guidelines recommend reducing or eliminating alcohol intake and simple sugars. Omega-3 fatty acids reduce the risks associated with CAD when eaten regularly. For individuals without CAD, the American Heart Association recommends eating fatty fish twice a week because fatty fish such as salmon and tuna contain 2 types of omega-3 fatty acids, EPA and DHA. Patients with CAD are encouraged to take EPA and DHA supplements with their diet. The American Heart Association also recommends eating tofu and other forms of soybean, canola, walnut, and flaxseed because these products contain alpha-linolenic acid, which becomes omega-3 fatty acid in the body. This picture here on the left shows saturated fats that we want to use sparingly, monosaturated up to polyunsaturated, which we should be using primarily. The nurse determines that teaching about implementing dietary changes to decrease the risk of CAD has been effective when the patient says, C. Monosaturated fats are found in natural foods such as nuts and avocados and are the main component of seed oil and olive oil. Canola oil is 57% to 60% monosaturated fat. Olive oil is about 75% monosaturated fat. And seed oil is commonly more than 80% monosaturated fat. Other sources include macadamia nut oil, grapeseed oil, ground nut oil, which is peanut oil, sesame oil, corn oil, popcorn, whole grain, wheat, cereal, oatmeal, safflower oil, sunflower oil, tea oil, camellia, and avocado oil. Fat intake should be between 25% and 35% of calories. Red meats should be reduced or eliminated from the diet. Only fatty fish such as tuna and salmon should be included in the diet because fatty fish is high in omega-3 fatty acids. We want to help encourage and teach our patients how to modify their favorite foods to monosaturated fats. Lipid-lowering drugs. The person with a serum cholesterol greater than 200 is at risk for CAD and should be treated. Treatment usually begins with dietary caloric restriction if the patient's overweight, and also decreased dietary fat and cholesterol intake, and increased physical activity. Serum lipid levels are reassessed after 6 weeks of diet therapy. If they remain elevated, additional dietary options and drug therapy can be considered. There are several classifications of drugs that are used to decrease serum lipids. The statin drugs are the most widely used lipid-lowering drug. These drugs inhibit the synthesis of cholesterol in the liver. An unexplained result of the inhibition of cholesterol synthesis is an increase in hepatic LDL receptors. The liver is able to remove more LDLs from the blood. In addition, statins produce a small increase in HDLs and lower CRP levels. Serious adverse effects of statins are rare and include liver damage and myopathy that can progress to rhabdomyolysis, which is the breakdown of skeletal muscle. These patients will have muscle aches, muscle pain. Liver enzymes are initially monitored and rechecked with any increase in dosage. Niacin or niaspan, a water-soluble B vitamin, is highly effective in lowering LDL and triglyceride levels by interfering with their synthesis. Niacin also increases HDL levels better than many other lipid-lowering drugs. However, side effects of niacin are common. Again, the myopathies that progress to rhabdomyolysis, which is the breakdown of skeletal muscle. These patients will have muscle aches, muscle pains. Other symptoms of side effects of niacin will also include severe flushing, pruritus, GI symptoms, and orthostatic hypotension. The fibric acid derivatives work by aiding the removal of the very low density lipoproteins and increasing the production of apolipoproteins. They are the most effective drug for lowering triglycerides and increasing HDL. They have no effect on LDL. Although most patients tolerate the drugs well, they might complain of some GI irritability. Bile acid sequestrants increase conversion of cholesterol to bile acids and decrease hepatic cholesterol. The primary effect is a decrease in total cholesterol and LDLs. Administration of these drugs can be associated with complaints related to taste and a variety of upper and lower GI symptoms. These include belching, heartburn, nausea, abdominal pain, and constipation. The bile acid sequestrants interfere with absorption of many other medications such as warfarin, thiazides, thyroid hormones, and beta-adrenergic blockers. Separating the time of administration of these drugs from other drugs decreases the adverse effects. Drugs that decrease cholesterol absorption, such as ezetimibe or Zetia, selectively inhibits the absorption of dietary and biliary cholesterol across the intestinal wall. It serves as an adjunct to dietary changes, especially in patients with primary hypercholesteremia. Drug therapy for hyperlipidemia continues for a lifetime. Concurrent diet modification is essential to minimize the need for drug therapy. The patient must fully understand the rationale and goals of treatment, as well as the safety and side effects of lipid-lowering drug therapy. Antiplatelet therapy, unless contraindicated for maybe an example, a history of a GI bleed, low-dose aspirin of 81 milligrams is recommended for people at risk for CAD. Current recommendations include low-dose aspirin for men over 45 and high-risk women, those with a calculated 10-year CAD risk, unless contraindicated. For high-risk women who are intolerant of aspirin, clopidogrel or Plavix can be substituted, and healthy women 65 or older, aspirin therapy should be considered if blood pressure is controlled and the benefit for MI prevention outweighs the risk of GI bleed or hemorrhagic stroke. Gerontologic considerations with CAD. The incidence of cardiac disease is greatly increased in older adults and is the leading cause of death in older persons. In the older adult, CAD is often a result of the complex interaction of non-modifiable risk factors and lifelong modifiable risk factors. Strategies to reduce CAD risk and to treat CAD are effective in this age group. Aggressive treatment of hypertension and hyperlipidemia will stabilize plaques in the coronary arteries of older adults, and cessation of tobacco use helps decrease the risk for CAD at any age. As nurses, we should encourage the older client to consider a planned program of physical activity. Activity performance, endurance, and ability to tolerate stress are improved in the older adult with physical training. Positive psychologic benefits can be derived from physical activity and can include increased self-esteem and emotional well-being and improved body image. For the older adult who is obese, making modest dietary changes and slowly increasing physical activity such as walking will result in more positive benefits than aiming for a significant weight loss. We want to assess these patients for what exercise do they enjoy. If we want to increase their exercise, we have to help them decide what they enjoy, because it's something that then they can stick with. When planning a physical activity program for the older adult, recommend the following: longer warm-ups, longer periods of low-level activity, longer rest periods between sessions. Heat intolerance in the older adult results from a decreased ability to sweat efficiently. Teach the patient to avoid physical activity in extremes of temperature and to maintain a moderate pace. The older adult should exercise a minimum of 30 minutes on most days of the week as able. Encouraging the older patient to adopt a healthy lifestyle may increase the quality of life and reduce the risk of CAD and fatal cardiac events. The older adult faces many of the same challenges when it comes to making lifestyle changes. There are 2 points in time when the older adult is more likely to consider change. 1, when they're hospitalized, and 2, when they have symptoms such as chest pain are the result of CAD and not normal aging. So first, assess the older adult for readiness to change, and then help the patient to select the lifestyle changes most likely to produce the greatest reduction in risk for CAD.